Welcome everyone. My name is Kate Blackburn. I'm a Senior Program and Policy Analyst with Nemours Children's Health System. We're thrilled to have everyone with us today. There's an incredible amount of interest in today's topic as evidenced by the fact that around 800 or so people are registered for this call today. We have a packed hour, so I'm going to jump right in with a little bit of background information, and then I'm going to turn it over to my colleague Rio Holiday from ChangeLab Solutions. Great. Nemours is an internationally recognized children's health system that owns and operates two full-service children's hospitals, Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and Nemours Children's Hospital in Orlando, Florida. We also operate pediatric specialty clinics in Delaware, Pennsylvania, New Jersey, Florida, and Georgia. And so though our physical presence is in the Delaware region and Florida, Nemours also works at a national level to help children grow up healthy. So through our National Office of Policy and Prevention, which I represent, Nemours collaborates with external partners to spread and scale effective innovations in practice and prevention nationally. Moving Healthcare Upstream, or MHCU, is a collaborative effort co-led by Nemours and UCLA's Center for Healthier Children, Families, and Communities. The work of MHCU is based on the notion that health systems can address persistent and costly health inequities by moving upstream, or beyond the walls of hospitals and doctors' offices and into the community, collaborating with community-based organizations to address the root causes of disease. The various areas of work within MHCU all share a common focus, which is on supporting hospitals and other stakeholders in testing and spreading strategies to move upstream, and in doing so to inform the field and accelerate upstream movement in the field as a whole. So this webinar series is one example of MHCU's work to spread knowledge in the field. We invited ChangeLab Solutions to co-present the webinars with us, given their expertise in providing training and technical assistance on the creation of policy strategies. So in just a moment, I'll turn things over to Rio to say more about ChangeLab, but I wanted to go through just a few important notes first. First, I'd like to again acknowledge ChangeLab Solutions as our co-host for today's webinar. If you haven't already, we encourage you to follow MHCU and ChangeLab on Twitter for more on this topic. Our Twitter handles are on the slides. I'd also like to let you know that we'll be tweeting during the webinar using the hashtag UpstreamLabs, and we encourage you to invite you to join in or follow along using that hashtag. I'd also like to thank the sponsors of today's webinar, the Kresge Foundation and Nemours Children's Health System. A huge thanks to both organizations. And finally, if you're interested in an opportunity to roll up your sleeves and kind of get to work on creating or strengthening your policy work related to today's topics, you might be interested in joining the Short-Term Policy Learning Lab that we'll be launching next month. So this is going to be a tremendous opportunity that we're really excited about. The Policy Learning Lab will provide customized coaching, technical assistance, and resources from ChangeLab Solutions, MHCU, and a national network of academic and on-the-ground experts. Members of the Learning Lab will participate in virtual group meetings once a month just from August through October, and will receive individual consult between meetings. So you can visit MHCU's website for details on the Policy Learning Labs and to apply. The link to the site for applying is in this slide, but it was also in the email of confirmation that you would have received and will be included with our follow-up information. We are taking applications through this Friday, and we'll be planning to announce members during the week of August 7th. So if you have questions related to the Policy Learning Lab, you can either email the MHCU team or you can call me at the phone number that's on this slide. And again, all of the information will be in the post-webinar materials that are sent out to you. So having laid the background, let's get started. Again, I'd like to thank Public Health Institute and Children's Healthcare of Atlanta for joining us today as presenters. And I'd like to once more acknowledge our co-host, ChangeLab Solutions. So at this point, I'm pleased to introduce Rio Holiday, a Senior Policy Analyst at ChangeLab Solutions. Welcome, Rio.
Thank you, Kate, and hello everyone. My name is Rio Holiday with ChangeLab, and if you're not familiar with ChangeLab Solutions, we are a public health policy organization located in Oakland, California. We work nationally on a range of public health issues from tobacco control to housing to food. We have a very interdisciplinary staff including public health people, urban planners, and attorneys. And because I work with lawyers, my slides come with disclaimers on them. And this essentially says that ChangeLab is a nonpartisan organization, and what I'm doing right now is not lobbying you. So now that that is out of the way, what I'm going to do in the next 15 minutes is give an overview of food insecurity, policy change, and talk about how to tie them together. And then I will hand it off to our next speaker. So first, let's get on the same page about food insecurity. Food insecurity means access by all people at all times to enough food for an active, healthy life. If you want to get more jargony, the USDA defines food insecurity as the limited or uncertain availability of nutritionally adequate and safe foods, or the inability to access foods in socially acceptable ways. I'm going to say that once more. So the USDA defines food insecurity as the limited or uncertain availability of nutritionally adequate and safe foods, or the inability to access foods in socially acceptable ways. And by getting food in socially acceptable ways, they're talking about not having to resort to emergency food supplies, scavenging, stealing, or other strategies like that. Food insecurity does not occur in isolation. So people experiencing food insecurity are making trade-offs between food and other necessities like housing costs, medicine, utilities, and education. A parent might make a trade-off between skipping their own meal so that their child can eat. The point here is that food insecurity is about being faced with limited resources and then having to make choices. Food insecurity can be sporadic or chronic. So a family could be food insecure during one part of the year and food secure during the rest of the year. There are different levels of food insecurity which the USDA has defined and measures. The definitions aren't important for this webinar, but the concept that there are different levels of food insecurity is because it expands the way we think about who might be experiencing it. So for example, some food insecurity households may be anxious about how they'll get food, but the actual quality, variety, and quantity of food they have isn't hugely affected, whereas other food insecure households may experience a decrease in the amount of food they eat because they don't have enough resources for food. And then finally, food insecurity is different from hunger and food access. So food insecurity is primarily about not having enough money or resources for food and having to make trade-offs between other necessities and food. Hunger is of course related, but it's a more personal physical experience. And then food access tends to be described more in terms of geographic proximity to sources of food. In terms of who's experiencing food insecurity, 1 in 8 Americans on average are food insecure. In 2015, 12.7% or 15.8 million households in the US were food insecure. And just as a note for other speakers, if you're not on mute, you may want to put yourself on mute. Thank you. 1 in 10 white households and 1 in 7 white children are food insecure. Now, compared to the national average and white households, 1 in 5 African American and Latino households are food insecure. That's double the number of white households. If we just look at children, then the numbers are higher. So 1 in 4 African American and Latino children are food insecure compared with 1 in 7 white children. Almost 2 in 3 seniors, or 17 million people about, are food insecure. And this is a population where the trade-off between medicine and food becomes especially clear. And rural areas are disproportionately affected by food insecurity. So of the counties with the highest rates of food insecurity, 75% are in rural areas. And of the counties with the highest rates of child food insecurity, 86% are in rural areas. Now, for this crowd, I don't think I need to go over the health effects of food insecurity, but I will say broadly that it affects health. So, for example, children who are food insecure are at higher risk for chronic health problems like asthma and anemia. It affects behavior. Children who are food insecure can experience behavior issues in school, such as fighting, hyperactivity, aggression, anxiety, mood swings, bullying. and it affects overall quality of life. So again, going with kids, it can prevent them from fully engaging in school or social interactions with peers. So now I'd like to talk about policy. When most people hear the word policy, they often think of an ordinance made by a city council or a law made by a state legislature. But both public institutions and private entities make policies, and there are a wide range of ways that policy can be made. And what we're seeing on the screen are a number of icons that show mechanisms for making policy. So the top two rows feature mechanisms for making public policies. We have local ordinances, zoning language, resolutions, school or government agency policy language, contracts and agreements, and state or federal laws. And then the bottom row features mechanisms for making private policies. So universities, organizations, and hospitals all have internal private policies. And if you think back to the disclaimer slide I had up earlier, that's an organizational policy at ChangeLab Solutions that our webinars have these slides. Now, whether it's private or public, a policy is a written statement. It is binding and enforceable, so there's some way to hold people accountable, and it's broadly applicable to a geographic area, type of institution or physical space, and or group of people. And the benefit of using policy to make change is that it offers accountability and enforcement, it reaches more people, it institutionalizes good ideas, and it often achieve significant results more effectively at lower costs, more efficiently. So for example, think about seatbelts. Before there was a law requiring seatbelt use, people weren't wearing them regularly. So even if you went out and educated people about wearing seatbelts, there's still no way to ensure that everyone was doing it. Now there's a law, and you have accountability and enforcement by police and by the fact that you'll get a ticket if you're not wearing a seatbelt. It affects everyone in the country. It's institutionalized this idea and social norm that or such that people who grew up with seatbelt laws don't question wearing a seatbelt, and it saved countless lives. So excuse this slow transition. I'm just going to skip a couple of slides. I was going to give everyone a quiz, but for the sake of time, I won't. I'd like to talk now about how you get to policy change, because you can't just start making policies left and right. So how do you get there? And the first thing that you need to consider is how ready is your community for change? And this is the Community Readiness Spectrum, which is taken from the Tri-Ethnic Center for Prevention Research at Colorado State University. They have a great toolkit on this online. The exact stages and definitions here aren't important for this presentation, but the point is to show that there's a spectrum of readiness for change. And when we talk about community readiness, that could be your organization, your hospital, or your jurisdiction. So if your community is not aware that there's even a problem, then you can't jump into policy change, right? You want to start with education about the problem. If your community is in this pre-planning phase where they're saying, this is important, what can we do, then you're still not going to jump into policy change, but you are going to start maybe researching strategies to see what you can do. Now, if your community is here in this confirmation/expansion phase where they're thinking, how well are our current initiatives working and how can we make them better, that's when you might start thinking about using a policy to institutionalize those current initiatives and making them reach a broader group of people. Or maybe you've already passed a policy and you're making sure that it's implemented and enforced well. So spoiler alert, I love spectrums, and this is our program to policy spectrum, which shows the steps that may take place as you increase community readiness and build momentum for a policy. So as I said on the previous slide, if your community is in the pre-planning phase, you might start by learning about intervention options. So you might then test an idea, see if it works or what needs to be changed in your community. Then you might expand it to a full-scale program in your community. And if this idea is working well, then you might start learning about how to use policy to institutionalize that idea. Maybe design a policy specific to your community, adopt it, and then continue to enforce and evaluate it. Now, this is a lot of information, but the main thing I want you to take away is that policymaking doesn't happen in a vacuum. It is a process, and it requires a lot of important foundation building, which can take time. You, I'm sure, have noticed the words program and policy on this slide. And in this context, a programmatic intervention is one that's time-bound, has a small reach, is voluntary, and might be vulnerable if, say, the program champion leaves. They're very important to build the community's readiness for policy change, but policy is where you want to go for more sustainable change. So as I described earlier, a policy is a statement in writing that's binding and enforceable and is broadly applicable to a geographic area, type of institution or physical space, and or group of people. The last thing that I want to mention before moving off this topic is that if you listened to the asthma webinar last week, my colleague Derek presented the same concepts just in a slightly different way. And he and I are saying the same thing. We're just talking about it differently. And I want to flag that in case any of our listeners are like, wait, this is not what the other Change Lab guy said. What is going on? So with that, let us talk about how we can use policy to address food insecurity, and specifically how restrictive covenants are a mechanism to create policy that affects food insecurity. So a covenant is a type of contractual arrangement, and a restrictive covenant restricts or limits what you can do with a piece of land. And I'm going to tell a story of two types of restrictive covenants and how their effect plays out in food insecurity today. And my goal here is threefold. I want to show how policy has created food insecurity, how it can be used to address it, and how important it is to think very carefully about equity and the potential unintended consequences of policymaking. And as a caveat, in order to keep this on point and concise, I am definitely going to oversimplify the issues that I discuss. So remember how I said earlier that food insecurity is about having limited resources and having to make choices with those limited resources, such as choosing between housing and food? Well, the first type of restrictive covenant in my story affects housing. So from the 1920s through the 1940s, racially restrictive covenants were used to prevent people of color from purchasing homes in white neighborhoods. The Federal Housing Administration required that deeds in these homes prohibited resale to black families. So white families started moving from cities out to the suburbs, and businesses, including grocery stores, followed them. But black families were prohibited from moving as well, in part because of these racially restrictive covenants. So at the end of this first story, you have suburbs with white families and a plethora of grocery stores, and urban areas with black families and fewer grocery stores. Now, the second type of restrictive covenant in my story affects supermarkets. It's standard in the supermarket industry to use restrictive covenants to limit another supermarket from moving in if land is vacated. So if a supermarket moves away, it's standard practice that the deed to the land would prevent another supermarket from moving in, and this can create food deserts. I don't actually know why this is a standard practice. In some cases, it could prevent competition if the supermarket was moving just a couple of blocks away, but restrictive covenants can prevent another supermarket from moving in for years after a site is vacated, even if the original supermarket moves out of town completely. So at the end of the second story, you have areas where a grocery store moved away and a new one is legally prevented from moving in. Now, racially restrictive covenants were found to be illegal in 1948, so the housing story I told is not current in that racially restrictive covenants don't exist anymore, though their effects are certainly felt today. But restrictive covenants in supermarket contracts are still a thing, and there are a few cities such as Chicago, Baltimore, and Philadelphia that either have or are trying to pass legislation that would limit these restrictive covenants if they would create a food desert. So let me step back and just highlight a couple of things in this example. So the first thing is that policy change is as much about creating new policies as it is about addressing the effects of bad ones. I could have shared an example here that looks forward and creates something new and shiny and exciting around food insecurity, but we're not going to get very far on addressing the inherent inequities on food insecurity if we don't look back on the policies that got us where we are today. The second thing I want to note is that this example focuses on land use and where supermarkets are located. This issue does tend to fall in the food access world rather than the food insecurity world, but I think it's really relevant here because it gets back to those trade-offs. So if a supermarket is far away, it takes time, transportation money, maybe childcare money to get there, and those are all resources that a family might choose to put elsewhere. So I'll leave you with a resource and a thought. This is a resource on our website for more information about parsing out what is a policy and what isn't. And my thought is that hospitals and health systems and providers have the potential to be huge players in policy change related to food insecurity. And two quick ideas that come to mind are that hospitals, healthcare systems, providers are all seen and respected as experts in a way that others aren't. And so getting hospital support, maybe that's a sign-on letter or showing up at a city council meeting or giving public testimony, would be huge for the credibility and visibility of policy change. And the second idea is that hospitals have huge resources to use, whether that's through using their community benefits or through the buying power that they have through procurement. The Bon Secours health system in Baltimore has built housing units for low and moderate income seniors, families, and people with disabilities. This is a really innovative private policy way to address those competing needs of people who are facing food insecurity. So thank you all so much. Here's my contact information. If you have questions for me, please type them in the chat box and I'll answer them at the end of the session. And with that, I will pass it to Holly Calhoun, Project Manager at the Public Health Institute. Take it away, Holly.
Great, thank you. And hello, everyone. I want to thank Change Lab Solutions and Nemours for having me here and for everyone for tuning in. So I'm going to talk a little bit more about how hospitals can partner with communities to address food insecurity as a social determinant of health through policy change. And I think, okay, I've got control of the slides, it looks like. Most of the examples that I'm going to share with you today came from the Tackling Hunger Project, which was a research initiative that was conducted by the Public Health Institute in partnership with CDC and the CDC Foundation with funding from ProMedica and the AARP Foundation. And some of you might know ProMedica and AARP as also founding members of the Root Cause Coalition that really is seeking to engage more healthcare stakeholders in addressing the social determinants of health. And the starting point for that initiative was really looking at hunger as a health issue. So through Tackling Hunger, we had, there are three components of that project. And you can go to the website, phihungernet.org, to learn more about that. But just real quickly, we did conduct an economic burden study to look at the cost of food insecurity on the health system. We developed a number of tools which are available on the website. Two that I think are particularly relevant for what we're discussing today are a guidance on how to incorporate food system assessment into community health needs assessments, and also an action brief on creating healthcare and community partnerships to tackle food insecurity. And we do have a couple of publications that are pending from that project that will be added to the website once those are made public. But the third component, which is really what I'm going to talk about today, was an exploratory evaluation, really looking at how hospitals and health systems are identifying and addressing food insecurity in their patient populations. And I'll just note that our study did have a particular focus on older adults, so age 60 and older. But most of the initiatives that we looked at were really inclusive of a much broader population, and so the programs and policies that kind of came from that can really be applied to a broader population. And so I think Rio really set us up with a good understanding of what food insecurity is and the impact that it has. I just want to add to that a little bit that the food insecurity rate is actually expected to rise, so it's already a pretty big problem, and it's expected that the food insecurity rate is going to increase for adults over 60 by 50% by 2025. And this is a problem, obviously for health and people who are suffering from food insecurity, but it also has a big economic impact on healthcare. So in addition to sort of the moral case for addressing food insecurity, there's also a business case. So food insecurity is very expensive, and we, as everyone knows, we spend a good amount on healthcare in this country, and the healthcare costs associated with food insecurity are estimated at around $78 billion just in the year 2015. And so when we talk about sort of the cost of food insecurity in terms of healthcare, we're really talking about this cycle of sort of increasing complications that come from food insecurity. So with Tackling Hunger, we developed this conceptual framework, which is actually based on a conceptual framework that was developed by Hilary Seligman at UCSF and Feeding America. But what the cycle shows is that there's a number of policy, environmental, and social factors that contribute to an individual being food insecure. And I think Rio talked a little bit about the ways that people are forced to compensate when they don't have adequate access to affordable, nutritious food to live a healthy life. And some of those compensatory behaviors might look like eating cheap, calorie-dense food with little nutritional value, even if someone knows that's not the best choice for their health, making it difficult to manage chronic conditions. So, for example, people who are relying on food banks for some of their food might be receiving a lot of pasta or white bread from that food bank, which may be foods that they know they're not supposed to eat if they have, for example, diabetes. But that's the choice to make, which all leads to increased health complications and comorbidities, which increases use on the healthcare system, right? So more readmissions, more medications, which worsens the financial impact on the individual, the health system, and also worsens the quality of life and health of the individual. And so when we think of the worst financial impact is not just paying for medications and care, but also transportation to get to and from care, and all the issues associated with that. And the cycle just kind of then continues and gets worse and worse. However, we can reverse the cycle. And so you see on the outside of the circle, there's a number of different intervention points that can really come in kind of anywhere across the spectrum. But community interventions, clinic-based interventions, hospital-based interventions are all incredibly important. But today I'm going to focus on the policy interventions. I think it's important to note too that in the examples that I'm going to share with you today, and I think was set up really nicely by Rio also, this all kind of works in a spectrum. So it's not that policy comes out of sort of nowhere, but oftentimes things are tested on the programmatic level and then able to be scaled or expanded or even sustained through a policy intervention. And really, when all these different levels of intervention are working together in a coordinated fashion, I think is when we can have the biggest impact. So through the Tackling Hunger Exploratory Evaluation, we put out a call for nominations to identify hospitals and health systems that were identifying food insecure patients with chronic disease and then addressing the needs of those patients. And we heard back from 59 nominations representing 27 states and selected 22 based on some specific inclusion criteria that we really drilled down on in more detail to interview and review documentation of their initiatives. And so most of the examples that I'm going to share today come from that process, though in some cases what I'm sharing is kind of updates from sort of how they've taken it more recently, taken some of the programmatic work they were doing into policy, or also just a couple other examples that we've heard about that are good and we'd like to share. So when we are thinking about how hospitals and health systems can address food insecurity on the programmatic level, just to give you a sense of what these sort of initiatives look like. I mean, what are we talking about here? We're talking about things like on-site food pantries or food pharmacies that may be providing medically tailored meals for people with specific chronic conditions, or acting as a food pantry on-site at a hospital, or referrals to off-site food pantries, fruit and vegetable incentive programs, so coupons for fruits and vegetables redeemable at farmers markets or grocery stores. We might be talking about a patient navigator program where somebody is really responsible for helping a patient access a number of different social services available in the community, subsidized CSA boxes, home delivered meals, or diabetes wellness programs that provide diabetic patients with medically tailored foods, as just some examples. And so just to give sort of one more plug before we shift to the examples of policy, sort of why it's important, I think, for hospitals to move from those, or to complement, I should say, the programmatic interventions with policy engagement. So hospitals are often one of the largest employers in their communities. They have many times access or influence with public officials. They're assuming increasing financial risk for poor health. More than 80% of what improves health is actually happening outside of medical care delivery. And advocacy is a really cost-effective solution. So all of the programs that I just mentioned, those cost money in terms of staff time, whether that's healthcare staff or a partner organization staff, and they cost money often in terms of the food delivered. And so policy can be a way to create really sustainable solutions, or to address the causes that are creating food insecurity and poor health outcomes to begin with. So what does it look like to actually talk about addressing food insecurity through policy at the hospital level? So many of the initiatives we were looking at with Tackling Hunger were screening individuals for food insecurity as sort of the initial starting point, and from there, referring them to the number of different services that I mentioned. And one of the most used screening tools is the 2-question validated screener from Children's Health Watch, and you can check out more about them on their website. They've got a number of great tools, especially when thinking about how to engage in policy. But essentially, patients are asked either intake or with their provider, these 2 questions to determine whether or not they're food insecure, and from there, if they are found to be food insecure, referred to other to the programs or intervention points. But what we heard from a number of the hospitals that we were talking with was that they found a really big difference when they formally integrated screening questions into their workflow, meaning it was not at the discretion of the provider to ask this question, but it was just an institutional policy in a particular setting or clinic to ask everyone who came through the door as a patient, these 2 questions to identify whether or not they're food insecure. And so in a particular in Hennepin County Medical Center that partners with Second Harvest Heartland on a number of programs to address food insecurity, weren't getting as many referrals as they expected out of a senior care clinic. And so institutionalized the routine standardized screening in that setting and found that in the first month their referrals jumped 1,460%, which is a huge increase, obviously. And so something is, as simple seeming as formalizing a process can really expand the reach of what they were able to do. And there's a whole case study at the Children's Health Watch website about the Hennepin County Medical Center and their work with Second Harvest Heartland. They also have a Health and Hunger program where they are actually collecting a lot of different data about the some different interventions that they have tailored to people with chronic disease. So they're able to then use that data that they're collecting to inform better institutional policies and also potentially to address policy on a local or state or even federal level depending on what they're finding. So I think data collection and evaluation is not something that we talk a lot when we necessarily. But it's really important if we want to be making the case for policy change on any level to have the accurate data to back up those arguments. So another institutional policy that can be used to address food insecurity is procurement policies. So I think folks might be familiar with this. Healthcare Without Harm does a lot of work around procurement in hospital settings, and they have a Healthy Food and Healthcare Pledge that institutions can take to really institute a policy within their own institution related to procurement. And the reason this can help improve food insecurity is that by hospitals sort of channeling the dollars that they're spending, whether it's on food items or actually on any items that they're procuring, if a percentage of those dollars are going into the local community to support local businesses, that improves the local economy, which decreases food insecurity. And I'll also note we had a good example from the Connecticut Mental Health Center, which is dealing with a population with severe mental health issues and very low income. And as a starting point for addressing their internal food environment and in food insecurity in their patients, they developed a healthy beverage vending policy within the institution. And that actually led to a big cultural shift within the organization because they did a lot of education with employees and with patients to roll that out and prepare people for the change, which they basically eliminated vending machines and did a big push for healthy beverages, mainly water. And that really educated staff. It led to a number of different programs now that are addressing food insecurity for their patients, including a Better Eaters Club, which provides cooking classes and how to shop on a budget classes for patients, and also involves screening all of their patients for food insecurity and primary care visits, and then providing nutritional counseling with them. So that's actually kind of an example of where making an institutional policy change then led to some other programmatic development to support really the goals that the institutional policy was trying to achieve. I'll just be real quick here. So another example that I want to share is from San Diego, where I think a lot of folks on the line do go through a community health needs assessment process. And I just want to note that the CHNA in itself can be a tool for policy change, something to sit down and meet with policymakers about to make them aware of the issues and needs within the community. And in this particular case, the CHNA identified an interest from community-based organizations to get support from hospitals on policy change, to have hospitals writing letters of support on specific initiatives, which actually led to the Hospital Association for San Diego and Imperial Counties adapting a policy agenda on food insecurity that was highly informed by the San Diego Hunger Coalition, who had been a programmatic partner with a number of the hospitals on addressing food insecurity. So I think the CHNA is a really good starting point. And I also want to encourage folks that partnering up with the organizations in your community who are really experts on the issue of food insecurity. I'm sure they exist in all communities, and working in coalition with those folks is probably the way to be most powerful. We don't all have to become experts on every issue, but working together we can make a big change. And I'm going to, with that, just come to the end. I have my contact information up, so if you have any questions, please let me know, and then I want to pass it off to my colleagues at Children's Healthcare Atlanta.
Great. Thank you, Holly. This is Wendy Palmer, and I'm here with Jennifer Pusto, and we are both managers on the wellness team at Children's Healthcare of Atlanta. And we're excited to share with you just a little bit today about our journey from community wellness to addressing food insecurity and how we're transitioning that from our community work into our hospital efforts as well. So I think to start with that, I probably need to just give you a little bit of background on the work that we're doing at Children's around wellness in particular. We have an initiative here called Strong for Life, where we've been working since about 2011 with a variety of partners in the community to really impact childhood obesity and wellness and health behaviors for our families in Georgia. And in particular, one of the components of that is our Strong for Life clinic, where we do offer medical management and treatment for overweight and obese children who are at the highest need. And Jenny's really going to talk a little bit more about that particular clinic and some of the pilot work we're doing there around food insecurity in particular. But I think, one of the questions we've been asked is, you're a wellness-based effort and obesity-focused. How does that really connect to food insecurity? And I think we all can recognize that there's a tremendous connection there, because our families who are being encouraged to make better choices with their food are really going to have trouble doing that if they don't have access to healthy food or the ability to feed their family over the course of a month. So I'm not going to really touch on the food insecurity background, because I think Rio and Holly have both covered that pretty extensively. But specifically here in Georgia, looking at our particular issue, we do have 1 in 4 children who are living in food insecure homes. So this is a little bit higher than the national average of 1 in 6 when it comes to children. And we've also looked at data from our particular Strong for Life clinic, and our patient population there is directly aligned with this. We have about 25% of our patients who are in food insecure homes. And just honing in a little bit more on that hunger and obesity connection, I think this is a crucial one for hospitals to think about, as they do have efforts in the wellness sector, and how does that really overlap with food insecurity. The 2 maps that you see here, the one on the left is obesity statistics for the state of Georgia. The darker green, the higher the prevalence. And the map on the right is from Feeding America, the Mind the Meal Gap data, which shows similar correlations there. The darker green areas with the highest food insecurity are also the areas with the highest obesity prevalence. And as many of the presenters have mentioned, these are areas that are more rural. There's less access to food. There's also less access to healthcare providers who may be addressing the issue of food insecurity in these particular areas. So it makes a great case for us as a pediatric healthcare system to really think about how do we connect hunger and obesity, and how do we address food insecurity for families in this particular area. In addition to that, I think many of you are probably aware of some of the different national organizations who have really put out some recommendations on how to address food insecurity in a healthcare setting. Of course, we are certainly pay attention to a lot of the American Academy Pediatrics guidelines, and they have a fabulous toolkit for pediatricians that really addresses how to integrate food insecurity screening, referrals, and conversations with families about that in the primary care setting. And their policy statement is one that our pediatricians are paying attention to. I think the challenge is how do they put that into action in their practice. In addition, the Diabetes Association and Feeding America both came out this year with guidelines for assessing patients for food insecurity. So there are many more resources to really facilitate this work happening at the community level and also in the healthcare sector as well. We also use the same two questions that Holly was talking about from the Child Health Watch organization. They're the ones that the AAP recommends in terms of screening for food insecurity. So these are the two questions that we are working to integrate with our primary care partners in the community, but that we're also utilizing here in our Strong for Life clinic with our families that are visiting us there. And I want to touch just briefly on some of the work that we've been doing with moving healthcare upstream around addressing food insecurity and connecting that to obesity prevention. So I don't have time to go into great detail on this project, but happy to discuss with anyone who's interested. But we are currently working at the community level to try to connect our primary care pediatricians in our Georgia WIC offices, who are obviously a food assistance program that is available to families. So in that 0 to 5 space, there are a large number of families in Georgia who are eligible for WIC services who do not participate in them between those ages of 2 to 5 year old. So we are working to try to coordinate the care of those families in the primary care setting and increase the referrals from the pediatrician to the WIC clinic. And in this work, we've really come across quite a few challenges in terms of instituting sort of that organizational policy at the primary care pediatrician level in the community, which these are all independent pediatricians, so they all have their own policies that they're adhering to. And a lot of it has been around physician education and physician understanding of food insecurity as an issue. And in particular, one of the things that the AAP is recommending, and I encourage the hospitals to think about, is how do we educate our community physicians on what food insecurity is, how it ebbs and flows over time, and the importance of screening families at every visit for this particular issue. Because what we have found with our pediatricians is that there is a lack of understanding and somewhat of a bias of who they believe their food insecure patients may be, which is not necessarily true if we're not screening every patient to see what they're experiencing at that time. In addition, there was a tremendous gap in knowledge with our primary care audience in the community in terms of what are the hunger referral resources in their particular community. Obviously, we're working to increase referrals to WIC as a resource for food, but also nutrition counseling, and there's a lot of misinformation about some of the food assistance programs. So part of our effort in the community is to provide education on that to our community physicians and how to have those conversations so that they are able to talk with families and screen families and make sure that it is clear to families they're asking because they care about their health and they care about the health of their family, and that food is a crucial component to your family being healthy. So that is some of our community work, and that's really what's brought us to think about how do we address this internally and institutionally here at Children's Healthcare of Atlanta. So I'm going to turn it over to Jenny, who's going to talk a little bit about our Strong for Life clinic and some of the efforts that we have been doing there.
So as Wendy said, we've begun to address our internal systems and policies for assessing and addressing food insecurity amongst our patients. We know that we need to address food insecurity within our own walls to lend support and validation to our community-based efforts. So we started with our Strong for Life clinic, which is managed by our medical director, Dr. Stephanie Walsh. With the Strong for Life clinic, we had a captive patient population, assistance from a CDC fellow, and an engaged physician leader. So we developed this 3-step patient screening and response process to begin testing. The process includes screening all new Strong for Life patients using the Hunger Vital Sign, reviewing screening results with patients and families, and responding to positive screens. In Phase 1, the response includes generalized and individualized resources in the form of a handout and a social work referral as needed. We knew this outline process wasn't ideal, particularly with respect to the handouts, but we had to start somewhere, and we were willing to try and to learn. So Phase 2 will include a more involved process, which I will discuss in just a bit. So as we shared our work within the system, we encountered some barriers which we had to work to overcome. Some of the biggest concerns voiced in discussions with leadership and others were related to medical liability, concern for abuse and neglect, and HIPAA considerations. Early on, there were concerns that screening for food insecurity would increase the need to report families for abuse or neglect. So prior to moving forward with this pilot, we sought advice from our legal counsel. And in short, we learned that food insecurity does not equal abuse or neglect, and that if a family declines assistance, that doesn't necessarily constitute evidence of neglect. And with respect to HIPAA, having patients complete written disclosure requests or authorizations is a straightforward way for covered entities to share patient information with food banks in a manner that is consistent with HIPAA requirements. And of course, for any system wanting to take on their own food insecurity project, I would advise you to consult with your organization's legal counsel. Perhaps one of the most critical components of this project has been the establishment of effective partnerships. In order to provide direct referral to community resources, it was imperative that we develop a relationship with a strong community partner who had the ability and the capacity to respond. Strong for Life engaged the Atlanta Community Food Bank in the early planning stages of the pilot, and we are very fortunate that this local resource already provides significant support and resources to the Atlanta community and has relationships throughout the state via the Georgia Food Bank Association. Additionally, the Atlanta Community Food Bank has in place a strong data management reporting system, which is going to help us track efficacy and demonstrate results to leadership. The Atlanta Community Food Bank has benefits counselors on staff, and they're able to help families apply for a number of supports and services, including food stamps, Medicaid, Medicare, WIC, temporary assistance for needy families, child care assistance, and benefits checkup. They're also able to refer families to food pantries and summer feeding sites. So to facilitate a relationship between our patients and the food bank, we developed a referral form which we plan to integrate into our electronic medical record system. And that's going to allow us to automatically fax a referral to the food bank. This warm referral has been proven to be much more effective than just simply handing the patients a list of local resources. And the form, which is available as a resource to this webinar, is modeled after a referral developed by Colorado Children's Hospital. So then where do we go from here? Phase 2 of our pilot, we're going to launch mid-August, expands upon our current work and includes a more involved response. So in Phase 2, we're going to screen every patient at every visit rather than what we're currently doing, which is screening only new patients. We're going to continue to review the positive screen results with families, and we'll document screen results and discussions with families in our electronic medical record system. We're going to introduce the warm referral process, which will provide that direct linkage to the Atlanta Community Food Bank. We're going to follow up with families at subsequent clinic visits, and we'll explore opportunities to offer on-site resources, including food pantries, community gardens, and potentially an on-site benefits enrollment support. And finally, we will work to develop an institutional standard of care, which will include formalizing our partnership with the Atlanta Community Food Bank, as well as updating our current process map based on lessons learned through the pilot. And that takes me to our current process map. So in the early planning and partnership stage, we developed this process map, which outlines the steps both parties are going to take on behalf of families experiencing food insecurity. And as I said, we're going to formalize our relationship with the food bank, and we are going to do so by entering into a formal memorandum of understanding. And that's going to solidify the roles and responsibilities of each party. And together we're going to evaluate the results every 3 months and then present the findings to leadership in support of a Phase 3 pilot, which we hope will include adoption of the program by children's outpatient clinics.
So that is just a little bit about sort of where we are in the programmatic efforts in our pilot work here to really influence our organizational, institutional policies that we have going on. And quickly, just to share a few kind of key things, I think we all probably know this, but it's really important as a healthcare institution to engage our physician leadership. which we did early in this project, and that really is helping to support the efforts that we have moving them forward. In addition, our community partners, the Atlanta Community Food Bank is a tremendous asset to the work that we have going on here, and they are also extremely engaged in figuring out how to help bridge that gap between the healthcare sector and the community resources that exist. And of course, expect barriers. Some of the legal issues, the HIPAA issues, those were things that we weren't expecting, but as they came up, you certainly have to address them, and I think sharing those lessons with other organizations is extremely important. And then, of course, just that quality improvement mindset, so small tests of things. Typically we think of a pilot, and our pilot has multiple phases because we're learning as we go in the process and making changes to adequately address that. I just wanted to share a couple of resources too in case anyone's working with community-level pediatricians, but there is a free toolkit from the American Academy of Pediatrics that offers a tremendous amount of resources for pediatricians, including things like this poster that they can hang in their office and detailed advocacy efforts, along with information about all of the different federal nutrition and hunger-related resources that are out there. So these are just a couple of the great resources out there related to food insecurity. And I think at this point we're going to hand it back to Rio just to kind of think through the questions if we have time for those.
So this is Kate Blackburn, and I'm going to jump in since we're just at 2 minutes before the end. We're going to send out a question and answer document because the level of enthusiasm has been tremendous. There's a ton of questions in our chat, and we're not going to be able to get to all of them today because of the amount of content. But our partners at Change Labs and we will work together to create a question and answer document to address all of your questions, and we will also make sure that you're linked up to if you had a question for individual presenters as well. So I'd like to kind of bring things to a close with a couple of reminders, or a couple of final statements. One is that in addition to sending out the question and answer document, our follow-up email that will go out to everybody that registered will also include a link to audio of the webinar. It will include a copy of the slides, which many of you asked about in the chat, resources mentioned by any of of today's presenters, and then the link to apply for the Policy Learning Lab that I mentioned at the top on the intro. So I'd really, really like to thank everybody for your tremendous level of enthusiasm for this subject. Encourage you to follow up individually with today's presenters. I'd like to again acknowledge and thank the Kresge Foundation and the Morris Children's Health System for their sponsorship, and I'd really like to close out again by thanking our co-presenters, Change Lab Solutions. So thanks to everybody, and be on the lookout within the next few days for the email that will provide you with the question, answer, and all of the follow-up resources. Thanks very much. Bye-bye.